second half of this presentation is going to be on the overview of fetal thoracic pathology. So we're completely changing gears. And again, I have no disclosures. And the purpose of this talk is really to review the standard planes for assessment of the fetal thorax. So really focusing on what views we need to get. And I'm going to talk a little bit about the key clues for diagnosis for common thoracic pathologies like pleural effusions, echogenic lung lesions, congenital diaphragmatic hernia, and what are some of the sonographic prognostic indicators we use in practice, particularly those that we use to select for often for prognostication and sometimes for fetal intervention as well. And briefly just touch on when we have to think about referring, as oftentimes there may be an option for fetal intervention in those type of situations. So we'll touch on that. So I think just to start off in terms of normal fetal chest imaging. So when we're looking at the lungs, we really actually just need the 4-chamber view of the heart. So if we're looking at the 4-chamber view of the heart and we're in a truly axial view of the chest, which means we have a single rib on each side, we shouldn't just be looking at the heart. This is the perfect opportunity to look at the rest of the chest, and we should always be training our eyes to do so. So what that means is you're looking at the surrounding tissue around the heart, which is the lungs. You want to make sure that the echogenicity is uniform. Typically, the lung is more echogenic than the liver. You want to make sure that the heart is pointed in the direction to the left, so it has the correct axis there. And you want to make sure that there isn't any cystic structures or fluid collections in the chest. A sort of complementary or a secondary view is looking sagittally at the chest. And I think really this is a complementary view. This is your key view to recognize pathology. But when you look at the sagittal view, you will see sort of a dome-shaped structure, which is the diaphragm. And the presence of that is telling you, helping you look at the integrity of the diaphragm. But really, even for diaphragm, to suspect an abnormality, we will look at the 4-chamber view. So those are kind of the key views. And the 4-chamber is, like I said, the main view of interest. So when you're looking for lung pathology, there's really 3 features that should guide you to think that there's something going on with the thorax. So first of all, it is usually a very substantial mediastinal shift. So we'll see the heart kind of squished to one side. And when we see that, we should automatically be thinking, well, of course, there's something going on with the heart, but more importantly, there's something going on in the chest that's pushing this heart to the side. The other very important feature that you'll see is abnormal echogenicity. So you'll have either hyperechogenic lungs, or you'll have hypoechoic or mixed echogenicity. It should normally be very uniform. So if it's not uniform in the normal echogenicity, then something is going on. The other important piece is the finding of a cystic lesion or fluid collection in the chest. Again, if you see something like that in the chest, then that is usually suggestive that there's something else going on. So we'll start with pleural effusions. And pleural effusions are pretty not uncommon in the prenatal world. And really to distinguish pleural effusions, we have to recognize the difference between pericardial effusions. So on the left of the screen, you have a pleural effusion, which is kind of floating freely in this fluid. And this video was playing for a sec there, but it should be floating freely in the fluid like a bat wing, and that's a pleural effusion. When you have a pericardial effusion, which is on the right of this screen, you see this fluid pushing the lung back, and the lung cannot move freely. It's just pushed and compressed. And that's a pericardial effusion. So the first important distinction is recognizing whether this is a pleural or a pericardial effusion. And that's of course important because it is very, it'll have very different workup and differential diagnoses and prognosis for that finding. When you know that it's a pleural effusion, then you want to know, is it unilateral? Is it bilateral? Is there significant mediastinal shift? Are there associated anomalies, particularly related to the lung, the diaphragm? You also want to see, is there hydrops associated with this? And sometimes it can be difficult to distinguish whether the hydrops is related to the pleural effusion or if it's part of the whole picture. And typically, if the hydrops is arising from pleural effusions, you'll have more edema in the upper body for the baby. You're going to have predominantly more fluid in the chest compared to the other compartments. So those are usually big cues or clues that this hydrops is coming from the effusions, but it's not always so easy and clear. When we see a pleural effusion, we have to work this up, obviously, and we really want to distinguish, is this a primary effusion or what we call a chylothorax related from a lymphatic type abnormality, or is this a secondary cause related to immune hydrops like Rh disease, or non-immune causes like genetic or structural abnormalities, infections, or anemia? Typically, anemia does not present like this. Anemia will usually present with ascites, infections as well, not typical with just effusions, but it is part of the workup. And typically that will include a maternal CBC, group and screen. We may do an electrophoresis depending on ethnicity. We want to look for fetal maternal hemorrhage with Becky. You want to do infectious serologies. Again, these are all probably to be low yield, but the really important ones are looking a detailed anatomical survey, looking for structural malformations, infection, ruling out anemia. An echocardiogram is particularly important to make sure there's no structural anomalies of the heart. And really offering genetic testing is key here because there is an increased incidence of aneuploidy as well as Noonan and Resopathy type syndromes. So it's really important to think about that. And if you're going to do a diagnostic or a therapeutic thoracocentesis or a shunt placement, that fluid can also be sent off for genetic and infection testing. Classically, we say that, if we do a cell count on that fluid and you have a high predisposition of lymphocytes, particularly above 80%, that this is probably primary. But that's actually not so helpful because most of these effusions will show a predominant lymphocyte makeup, but we do sort of typically send it as well. So when you've sort of decided this is likely a primary pleural effusion, a proportion of them will spontaneously resolve. That's only about 20%. And these are typically small, unilateral, and there's no high drops. The image on the screen here is not a effusion that's going to resolve on its own. This is only going to get worse. And most of these will actually progress. And what happens is that you get increased intrathoracic pressure. This pushes on the lungs. We get pulmonary hypoplasia. We also get esophageal compression with swallowing issues and polyhydramnias, as well as fetal hydrops. And about 60% of these will survive without treatment. And especially in the hydropic fetuses, there's a high chance of mortality with only about 30% that will survive. So in these very severe, rapidly progressive effusions, or those that are hydropic, we will offer shunting to actually drain the fluid. And the survival does increase in a statistically significant way, particularly for those that are hydropic. And so that's something we will offer for these more severe lesions. So again, just to summarize, when you have a pleural effusion, you want to figure out, first of all, is this unilateral or is it bilateral? Is it hydropic? Is there substantial mediastinal shift or polyhydramnias? And these are all to really assess the severity. If they're very large and there's a significant mediastinal shift or they're rapidly progressive, this should be sent to a tertiary center where they can offer potentially fetal intervention. If they're small or moderate, then these should be followed weekly. And if they sort of worsen over that weekly assessment, or they get larger, then again, they should be assessed in a tertiary center where possibly fetal intervention may be an option. So again, those are sort of the main key, points to look for when we're assessing pleural effusions. Now moving on to echogenic lung lesions. So I've kept this broad, and it should be kept broad because by ultrasound, we're not really good at actually predicting underlying pathology. We should be referring them as echogenic lung lesions. And in fact, the pathology doesn't actually matter because we tend to manage these all very similarly. So we typically talk about echogenic lung lesions as congenital cystic adenoid lesions, CCAMs or CPAMs as one type of echogenic lung lesions. These are bronchiolar, like airspace proliferative disease. They have no systemic feeding vessels, so they get their blood supply from the pulmonary circulation. They communicate with the tracheobronchial tree. In terms of the pathology, there are there were originally 3 classifications, and now there are more than that, about 5. But by ultrasound, we only really care whether they're macrocystic or microcystic. And so by ultrasound, if we see cysts larger than 5 millimeter, we call them macrocystic CCAM. If they're large, echogenic, where you don't actually see the cyst, these are microcystic. And a small proportion, or not small, about a quarter, will actually be mixed, where they have a bit of a solid appearance and a macrocystic type appearance. Then we have sequestrations, which are non-functioning bronchopulmonary tissue. There's no communication to the tracheobronchial tree. These are solid triangular type echogenic masses. We say typically a little bit more on the left side, but they could be on either side, I should say. They have a systemic feeding vessel from the aorta. So if you look hard enough, you usually will find it. And you should remember that about 10% of these are actually infradiaphragmatic. So if you have a suprarenal mass, you should think about a sequestration in your differential diagnosis. And you should also look for associated anomalies, because sequestrations actually arise when the foregut is sort of dividing into the respiratory tract and the gastrointestinal tract. And so you can often have associated anomalies of those other tracts, or the diaphragm as well, so the gastrointestinal tract or the diaphragm. So it's important to look around as well. And in about 6 to 10% of cases, you will actually have an associated pleural effusion as well. So just those are some kind of signs that may be suggestive of a sequestration rather than a CCAM. So how do we actually assess which of these lesions are actually going to give us a problem? Fortunately, most of them don't give us problems, but there are some that will rapidly expand and we run into a risk of hydrops. So how do we assess that risk of developing hydrops? We actually just measure these lesions in 3 orthogonal planes, and that gives us a risk assessment of developing hydrops. Specifically, if the CVR is above 1.6, so what we do is we measure it in 3 planes, we reference it to the head circumference, and we get a number. And if that number is more than 1.6, which is the CVR, this is a significant risk of hydrop. So these babies actually need to be followed pretty closely. If you're not in that range, you're unlikely to run into trouble. We also know that the growth of these lesions typically grows until about 26, 28 weeks, and then it starts to slow down. So in that initial period, it's really important to keep a close eye. We tend to see them every 1 to 2 weeks, depending on the size of the lesion. And then after that point, we will space out the visits. And these lesions will typically vanish around 32, 34 weeks. In fact, they're not vanished. We just don't see them so much by ultrasound anymore, but on postnatal X-ray, you usually will still see them. The only caveat to this are the macrocystic ones, so the large cystic lesions, and even if they're not so large, because those small cystic lesions can also rapidly expand. So those ones we keep an eye on closely, typically till the end of the pregnancy, because sometimes it can be quite unpredictable in terms of their growth patterns and may need some kind of intervention. So when do we actually intervene, or when should we think about referring? So it's typically the hydrops and the rapidly progressive lesions. Historically, there was some fetal surgery that was offered where the lobe of that lung tissue was actually removed with open fetal surgery. This had obviously significant maternal morbidity without such an impressive fetal survival. So this was kind of fallen out of favor. We do use minimally invasive type of approaches to actually treat these if we need to. So things like steroids, as well as sometimes ablative treatments for fetal feeding vessels or drainages if there's a significant fluid accumulation. But all that to say that if they are significantly rapidly progressive or hydropic, those are reasons for these pregnant moms to be seen in a fetal therapy center where they may offer some kind of treatment. So again, to summarize, when you see these echogenic lung lesions, you want to know, are they microcystic, macrocystic, are they mixed? Is there vascularity from the systemic circulation? Is there a significant mass effect by mediastinal shift, the flattening of the diaphragm? Is there polyhydramnios? And we talked about the CVR, and the presence or absence of hydrops and other structural anomalies. And again, this is just a picture here looking at the diaphragm and its inversion. So that's a very significant mass effect from a large macrocystic CCAM. So just a final echogenic lung lesion. So this is a very large bilateral echogenic lung lesion with a centrally displaced heart, a very dilated trachea here on sagittal view. You see, again, a flattening of the diaphragm, a protuberant abdomen with some ascites. This is, of course, congenital high airway obstruction with a laryngeal atresia. These infants or these pregnancies are unfortunately have a very poor outcome, but an important differential diagnosis when we see echogenic lung lesions bilaterally that we should be thinking about a high airway obstruction. So final few words on congenital diaphragmatic hernia. So diaphragmatic hernias are not common, but again, we do see them in the prenatal world. Majority of these are left-sided. And it's really important to know that about 30 to 40% of diaphragmatic hernias are actually associated with other genetic or structural abnormalities, most commonly cardiac anomalies. And so it's really important to have a detailed look at the baby and also have an echocardiogram to look at the heart with the cardiologist, and also to really strongly consider genetic testing, because often this can just be the tip of the iceberg. So one of the most striking features that we all have seen is this very marked mediastinal shift. We often get these referral for dextrocardia. In fact, it's not dextrocardia. It's the heart is being shifted to the right side. It's still pointing to the left. So it's what we call dextro position of the heart with the left diaphragmatic hernia. Or you can see a significant shift to the left of the heart with the large right diaphragmatic hernia, as you see in this picture. Sometimes you'll actually see that there's quite a bit of a mixed echogenicity. Often, if you look hard enough, you'll actually see peristalsis of the bowel loops. Again, very typical of a diaphragmatic hernia with bowel herniation. The other big clue is the presence of a cystic structure in the chest, which of course represents the stomach, and that is often a very important cue to a diaphragmatic hernia. But sometimes you have a hernia where the stomach is actually in the abdomen. And the only clue is that the stomach is in an abnormal position. So if you see a stomach or a gallbladder or both close to the bladder, you should be thinking about a diaphragmatic hernia, because what happens is that in some hernias, which are typically smaller and later to diagnose, you only get bowel in the chest. And when the bowel goes into the chest, the stomach takes on a bit of a funnier position, and it typically is near the bladder or the gallbladder as well. So when you see those abnormal positioning of the stomach or the gallbladder, you should be thinking about a diaphragmatic hernia. The other important clue is looking at breathing. So we all do biphysical profiles. So pay attention to the diaphragm, making sure that it's moving up and down in unison. Sometimes what you'll see with diaphragmatic hernia is that there's paradoxical breathing, which you'll see that part of the diaphragm goes down appropriately. But in fact, what happens with the other side is that the diaphragm doesn't actually move down, and what's in the abdomen is moving into the chest. So you get this kind of paradoxical breathing that we refer to that is very pathognomonic for CDH. And this was a patient that was referred to us for a right effusion for consideration of fetal therapy. But in fact, when you look on sagittal views, there's more than just a right effusion. There's actually part of the liver in the chest. And this is actually a right-sided diaphragmatic hernia. So we need to be very careful when we see an effusion, like I said earlier, that you need to make sure that there isn't something else going on. And of course, a diaphragmatic hernia is a very different prognosis than just a small right pleural effusion. So again, really important to kind of look around and make sure nothing else is going on. So we know that with diaphragmatic hernia, the main causes of morbidity and mortality are related to the undergrowth of the lungs, as well as the abnormal development of the pulmonary vasculature. And by ultrasound, we're pretty good at predicting how underdeveloped these lungs are to really understand how this particular baby or pregnancy is affected or how severely it's affected. And how we do this is that we actually measure the lung on the opposite side of the defect. We measure the size of that lung, which I'll show a little bit how to do that. And then you reference that to the head circumference and you get a lung to head ratio. And you reference that to a baby who does not have this condition. And then you get an observed to expected lung head ratio, which yields a percentage. And basically, the lower the percentage, the worse the outcome. In terms of a severe diaphragmatic hernia, we usually define this as an O to E LHR of less than 25% for left CDH and less than 50% for right CDH. So these are kind of often the numbers we use for counseling as well, but this is kind of just to understand the principles behind this prognostic indicator. So how do we actually measure this? Again, emphasizing you need an axial view of the chest where you see a single rib on each side. You have the contralateral lung. So for left CDH, the right lung and the heart up there close to the transducer. You want to trace out the lung, which is the method we found to be the most reproducible. So you want to trace out all around the edges of the lung. You want to leave out the mediastinal vessel. And this is a really magnified image that really allows you to appreciate those details. And then you take the head circumference like we normally do, where you see the CSP, you see the ventricles, you don't see any cerebellum, and then you get a LHR at a certain gestational age. You go to this website, the Total Trial website, and you put in that information and they'll give you a percentage. And that's what you can help use for counseling. And this is all available in a recently published guideline that we put together for the North American Fetal Therapy Network, if you want to refer it, but those are basically kind of the highlights. This is how we do not want you to measure the O to E LHR. So these views are all incorrect because they're not axial views. The lungs are far from the transducer. We see multiple ribs, so really suboptimal imaging. Really what you want, again, is a true axial view of the plane where you see the lung close to the transducer, you see a 4-chamber view of the heart, and you want to trace out the lungs as best you can with an appropriately magnified image. So the other predictor is looking at liver herniation. Again, on 2-dimensional imaging, you can see the liver often in the chest. You can see the hepatic vasculature. Color Doppler will also help you identify the hepatic vessels or the ductus sort of tracking towards the chest. These are all important tools because we know liver herniation is a poor prognostic indicator. We also looked and published a standardized assessment for stomach position as well, because stomach position actually is a more easier tool to assess liver herniation, because the more liver you have in the chest, you actually see that the stomach is actually moving further back into the fetal chest. And so actually, if you sort of draw a line at the atrioventricular valves as a reference point, you'll sort of see the stomach in relative to that. So for a grade 1 stomach position, the stomach is in the abdomen, so it's sort of a normal position. Grade 2 is where you have the stomach in the chest, but it's just touching the anterior chest. And then grade 3 is that, yes, it's sort of crossing into the mid chest, but most of it is still in front of this line. And then grade 4, the most severe form, is all the way in the back part of the chest, and all of this is liver. So all of this has pushed the stomach way into the back. So this is suggesting more severe liver herniation. And stomach position has actually been correlated with neonatal or perinatal morbidity and mortality as well. So it's also an important, and I would say a little bit more of an easier tool to actually assess liver herniation as well. So again, why does this all matter? Well, because in recent times, we actually have a very good fetal intervention available for severe diaphragmatic hernia that was recently published in the New England Journal of Medicine just last year. So what we offer is fetal endoscopic tracheal occlusion for severe diaphragmatic hernia, where we actually put a little balloon fetoscopically to occlude the trachea. And this basically sort of promotes lung growth and pulmonary hyperplasia for these diaphragmatic lungs. We insert it around 26 to 28 weeks, and we remove it ideally around 34 to 35 weeks. And in severe diaphragmatic hernia, if we compare this intervention to just standard postnatal surgical repair, this has been shown to improve survival. It does come with an increased risk of preterm labor and preterm rupture of membranes, but still a significant improvement in survival. So again, it's really important to identify the most severe forms of this condition so we can offer fetal intervention for families who are wanting this type of treatment. So just again, some final summary about what we talked about. So we should be suspecting fetal thoracic pathology on the 4-chamber view of the heart if we have the presence of mediastinal shift, abnormal echogenicity, cystic lesions within or fluid collections within the chest. We want to look for evidence of this, because usually this results in increasing intrathoracic pressure, which ultimately the end result for all of these conditions are pulmonary hyperplasia, polyhydramnios with the risk of prematurity, eventual high drops, and death in the more severe forms. We talked about some of the prognostic indicators, mainly high drops for all of them, but also CVR for the echogenic lung lesions and OD-LHR for diaphragmatic hernia, and why it's important for counseling, but also potentially the role for prenatal intervention in the most severe forms of these severe conditions diagnosed prenatally. So thank you all for your attention. I know that was a long session that I put together, but I'm happy to take questions from the audience.
Wow, thank you so much. We do have some questions. I want to also thank you for doing 2 full presentations in one, and us pretending that it's only one. So it's double the work, and but absolutely fantastic. And yeah, the first presentation for sure, absolutely just exactly what I feel and believe. So thank you for leading the way in improving the quality of obstetrical ultrasound, not just in our urban MFM centers, but for everybody. So we'll be in touch, but okay. So we'll have a couple of questions about that to start with. So that being said, how can we make protocols and image standardized across Canada for all centers? If you were to say, I mean, other than starting like today, what we did as step 1, what would be your next step to say, how can we make sure that our sonographers in Yellowknife, who are there's some today, as well as Iqaluit and Grand Falls, Newfoundland. How can we ensure that we can keep that standardization and quality?
Yeah, I mean, I think it's a fantastic question, and I think we can devote our lifetimes to improving standards and quality. I think, like you said, I think initiatives like this are so important to highlight the needs and to address some of that with educational tools. But I think we just have to get out there. I mean, there's so one piece of it is, first of all, standardizing the guidelines across the country and internationally. Unfortunately, I think the SOGC guidelines are not up to par in many ways. I think that they don't reflect the standards we need to meet. And part of it is because we don't necessarily have those standards available across the country. So I understand that. But then I think it's our job for the the individuals who have the luxury of working in these big centers, that we go out and do our job and help train people in more remote areas, and kind of doing the hands-on kind of work we can do and support the training. And I think the other big tool is that with the telemedicine kind of tools that we have, and I sort of touched on that briefly, and I think Titi will also kind of touch on that, is that we have a lot of options with Zoom, and with COVID, we've learned all this virtual stuff with telemedicine that we can actually use, and to actually train so many other individuals in other areas, so we can up the standards everywhere. And I think we as individuals have that responsibility, and we all have to take that on ourselves in some way. So I think definitely getting out there hands-on and doing it. And if we can't do it so much, I think there's a lot of virtual opportunities to do it as well. And I think the other piece is really feedback. Like, I often find, we all kind of are, upset by the delays in referrals or whatnot, and we all have the same experiences, but you have to get out there and get that information back out, because I think we're all trying to do our job well. It's just sometimes we're not aware of what we're doing or what we could do better. So I think we also have that responsibility. But there's no easy solution. And, I'm glad to hear that there's like over 1,000 people here, because it gives me hope. I think we all care. I think we just have to kind of work together and do this. But I don't know if that's a really concrete answer, but yeah, I mean, that's what I felt after working with ISWAG, that we just have to we have to do our own parts, and work together to support each other.
Yeah, and I think, you make some great points, especially in that it's not just the didactic portion. It's not just attending conferences. It truly is about, the hands-on training and making sure that just because somebody is doing obstetrical ultrasounds, it doesn't mean they're doing them well. And how do you know if you're doing something well? Well, again, if you work in a MFM center, you'll have a maternal-fetal medicine providing that feedback. But, why this is an area of passion for me is that I deliver babies and I see what happens on the other side. And so, and a lot of sonographers don't get that. So I think feedback is so important. And then, of course, as you said, the importance of auditing, and that was sort of our next question, is how often should we have OB audits and who should be the one doing the audits? And I know I want to answer these questions too, but I'm going to give it to you.
Yeah, so I think first of all, recognizing that we need to do audits are really important. So, and I think it has to be on a kind of a regular cyclical basis. I think it's a big time commitment and a big sort of it's a big job essentially. And even in the Netherlands study, we're talking about hundreds of hours that it takes to do this. And even when we did it for ISWAG for individual trainees, it took hours and hours to do this well. So it's a big commitment, but it's an important one. I would say that, generally it should be at least on an every year or 2 year, that kind of cycle. That's kind of what they're doing in the Netherlands from what I can see. And they're kind of a really good example of this. And I think it really has to be sort of the lead educational sonographers, the consultants have to be part of this as well, the physicians. And I think we have to kind of do that individually. We have to do this to ensure that we're doing our job well. But operationalizing it is also a different task, because where do we get the time to do this? We're all stretched thin and we all have our other responsibilities, but I still think it's important. And I think it's important part of providing our care effectively. But I don't know, Stephanie, maybe you have some ideas about what you think.
Yeah, no, I agree. I think the important thing with the audits is that one is that people have to recognize, and feedback is meant for a reason, and it has to be done by somebody who is an expert in that area, and it has to be done, regularly, as you said, and you have to have a degree of quality, which means also the feedback for outcomes, because you can think your images are great as much as you want, but if you have cases that are being missed or overdiagnosis, which is also a problem, then that feedback needs to come back as well. So I think it has to happen. We have to prioritize to make this happen, and because it matters for patients. So I do think, again, as you said, and using the role of telemedicine for sure, and maybe having, from a national perspective, actually having sort of maybe an auditing for obstetrical imaging. One key thing I think is important is the idea that you can't, like you said, how many 100 hours it takes. You can't be good at obstetrical ultrasound if you only do 10 detailed ultrasounds a year. I think that really does that as a group that is developing skills. You have to find a small set of people who are really going to be focused and passionate about improving the imaging in their center, and then once they are experts, then they train up other people, and really trying to focus that. So even though it might be great to provide ultrasound every day of the week across a city, it doesn't mean that that's best for patients in terms of the quality. So really important to maintain that. But sorry, I could talk forever on this. I do want to move just quick to the CDH questions. So it says one question was, do you trace lung circumference or area? And I think you responded to that, but I don't know if you wanted to say
Yeah,
why
so
you.
that's a question that's very dear to my heart because I spent my whole master's on this question. But anyways, so we actually looked at. I think you're asking about how to measure the lung area. That's what we're talking about, right? Yeah. So this was actually data that we collected from the North American Fetal Therapy Network. So what we basically did is, some of you may know, is that you can actually measure the lung area in 3 different ways, and I didn't get into it just for the interest of time. And so people in different centers basically do it in different ways depending on their own preferences and their own experience. And so what we did is we basically circulated CDH images across the North American Fetal Therapy Network, which is a network of about 50 fetal medicine centers. And we asked them to measure lung area using these 3 different methods that were available in the literature. And what we found is that tracing the contour of the lungs was the most reproducible across the unit. And this was also shown on a smaller scale in the European centers as well. And so based on that, we actually recommend tracing the lung area rather than, drawing the longest diameter, which is frequently reported, or the anterior posterior method. And that's just based on reproducibility. It's not that it's necessarily the most accurate, because we don't actually have a gold standard for lung measurements, but it is the most reproducible. So if I'm communicating with Stephanie, then we can be sure that we're actually communicating the same numbers. So that's kind of what we recommend based on that. And that's why I showed that way of measuring the lungs.
That's great. Thank you. And I think that's a really key point too, is that you have to have things that are reproducible and consistent. It's very difficult for a patient who gets very different every time they come for an ultrasound. Oh, this is lethal. Oh no, this is a good prognosis. So for sure. And then one last question, because I know it's time for the movement break. What do you think, when is the best time to do your fetal lung volume assessment, or the OE LHR? Do you do it, what's the best gestational age, and do you repeat it as time goes by? Does it, so because...
Yes, great question. Great question. So the observed to expected lung head ratio. So initially there was a lung head ratio where you just took that individual fetal measurement. But what was shown was that as the baby gets bigger, that number actually varies. So it's not gestational age independent. So what they developed was the observed to expected, where you reference it to a baby that does not have that condition. And so that's where you get that percentage. And in fact, it should not really change with gestational age, and it typically doesn't. But I do find that technically it's a little bit difficult often when they're really early on to get a really good measurement of the lung. So there's probably some technicalities with it. But when you typically make the diagnosis, they are around the anatomy survey. And when you're going to prognosticate them and provide some kind of counseling, you're going to do it at that anatomical survey type time. What we'll do is, so we'll do it then and we'll counsel them based on that number, but we really go by our numbers at 26 to 28 weeks, because that's actually where we offer fetal intervention. So usually it's the similar, but that's typically the timing of intervention to kind of classify the severity as well. And it usually doesn't change much, but in terms of fetal intervention, that's a key period of time.
That's incredible. Great. Thank you. Well, thank you so much for attending. We could have a conference that is just you all day.
No, no, that would be a boring conference.
No, not at all. Yeah. And I keep saying the idea of, oh, no, we are not going to do this next year, but we probably will. And we hope you'll come back again. And we are now going to, so have a great day. I think it's snowing out in Toronto. And we're going to move on to a little coffee break and movement stretching, because everybody is probably a little sore right now. So, okay. Thanks again, Nimrah.